Hello everybody, welcome aboard to my channel, Dr. Y Chest Radiology. Let's enjoy the chest radiographs with Dr. Y. Today's session is number 24, anterior prevascular mediastinum, 2/4. I know everybody, all of you are very smart and sincere, so I think you already understand and memorize session 23 all about the mediastinum and especially the compartment. Today's session is about prevascular compartment. The other name is anterior mediastinal compartment. Let's go. Boundaries of prevascular compartment. You already know about this. Superior, thoracic inlet. Inferior, diaphragm. Anterior, sternum. Lateral, parietal, mediastinal, pleural of both sides. And most importantly, the posterior boundary. That is, anterior aspect of pericardium as it wraps around the heart in curvilinear fashion. You remember, sure? What's in there? In prevascular compartment of mediastinum in normal condition. Number one is thymus, most important organ, the thymus. And second, fat tissue. And third, various lymph nodes. And fourth, left brachiocephalic vein. The diseases of the prevascular compartments are like this. First, thymic lesions such as cysts, hyperplasia, thymic epithelial neoplasm such as thymoma, thymic carcinoma, thymic carcinoid, thymolipoma. And B, germ cell tumor such as teratoma, seminoma, non-seminomatous germ cell tumor, NSGCT. And C, lymphoma. And D, metastatic disease. And E, thyroid goiter and parathyroid. Non-neoplastic lesions of the prevascular compartments are like this. First, intrathoracic goiter. B, thymic hyperplasia. C, cysts such as thymic cyst, pericardial cyst. D, vascular lymphatic abnormalities. This is the sagittal CT image of mediastinum, which was named by ITMIG on CT-based prevascular compartment. I think you sure remember this burgundy-colored area. Retrosternal, prevascular, before, in front of heart, in front of aorta, actually in front of anterior pericardium. Just memorize as the burgundy-colored area. This was written by Dr. Carter at Radiographics year 2017. This is actual CT image of a prevascular compartment. This burgundy-colored area is all about prevascular compartment. And today's session will be about the pathologies occurring, rising at these areas. When we are reading the film, interpreting the chest PA film, let's just focus on several points. That is, number one is mediastinal line obliteration. 2. Hilum overlay sign. 3. Silhouette sign. 4. Cervical thoracic sign. 5. Thoraco-abdominal sign. 6. Mark band effect. 7. Retrosternal triangle. Yes, I know all of you are surely well memorized these items, these signs. I introduce you to several facts about the prevascular compartment lesions before entering the case studies. First, more than 50% of mediastinal masses occur in prevascular compartment. Chest radar film and CTs are essential for prevascular lesions. Thymic tumors are usually for middle-aged people. Teratoma is for young people. Seminoma and non-seminomatous germ cell tumors are for young men. Thymic cysts, cystic teratoma, and cystic cymomas are usually not easy to be differentiated. Right cardiophrenic cysts are probably pericardial cysts. And non-seminomatous germ cell tumors usually have elevated alpha fetoprotein or beta HCZ levels. This is case number 1. This is middle-aged man's chest PA film. What do we see? Yes, normal looking. We don't see any abnormality with this film. In this axial and coronal contrast-enhanced CT, we see the soft tissue density mass with calcification with mild and diffuse contrast enhancement at 3 cm length. Yes, this is thymoma B1. This is the case number 2 with a middle-aged man. What do we see? Yes, irregular margin, the bulging contour on right paratracheal area, obliteration of a right paratracheal stripe. And how about the left side? Yes, also there is increased opacity with slight obliteration of ascending aorta margin. Increased mediastinal width. How about the lateral film? Yes. Retrosternal triangle is not black. The upper side is white with obliteration of ascending aorta. So we can imagine its prevascular compartment mass. How about these two axial contrast-enhanced CT of upper level and lower level? Yes, heterogeneous, irregular margined soft tissue mass with heterogeneous enhancement embedding inside of AP window and another nodule, probably lymph node. And there is 1 centimeter nodule in left lower pleural or lung. So this tumor looks very aggressive. Yes, it was confirmed as invasive thymoma. How about this case 3, chest PA film? Yes, bilateral, mediastinal, mass, increased opacity, widened mediastinum, obliteration of paratracheal stripe. Yes, aggressive looking tumor here in the mediastinum. On this axial contrast enhanced CT, we see a mass, very aggressive looking irregular margined tumor embedding into the vascular structure with heterogeneous enhancement more than 4 or 5 centimeters. Yes, it was proven as thymic carcinoma. When we see the anterior mediastinal mass more than 5 cm with a solid portion, thymic carcinoma should be suspected. This coronal image is recurring of tumor after chemotherapy and radiation therapy. And we also see the liver metastasis here. Yes, very aggressive tumor, thymic carcinoma. What about this young man's chest PA film? Is his right heart border normal? Abnormal? Actually, I don't know. How about the lateral film? Is this normal heart or something strange? I don't know. These two films are looking normal to me. This is CXR, contrast enhanced CT. Actually well-defined, clear margin, sharp margin. A retreating right heart border. Yes, this is cyst, non-enhancing cyst. And there is a fatty density here. Yes, it was proven as mature teratoma. How about the bulging contour here? Yes, it was teratoma. This was the pathology, teratoma with a fat density here. The case number 5. This is young women's film. Frontal film. What's wrong? This one does not looking good. Well-defined, sharp margin, homogeneous density, but heart border and descending thorax aortic border is preserved, looking normal. Then where is this mediastinal tumor? Okay, let's look this lateral film. Retrosternal triangle is not complete. There is something increased opacity here about ascending aorta level. Let's confirm with the CT. On this non-enhanced axial CT, this is the tumor at the prevascular compartment, not touching descending aorta, not touching paraspinal line, not touching heart, just touching ascending aorta. Yes. Upper portion is fat density. Lower portion is soft tissue or fluid density. We say this as fat fluid level. Most pathognomonic characteristic findings of fatty teratoma. This is case number 6, with most characteristic feature of anterior prevascular compartment mediastinal tumor. What do we see? On this young man's film, we see well-defined lentiform or mediastinally broad-based mass, almost homogeneous density. Please look at the pulmonary artery and bronchus. Where are they? This is bronchus intermedius. This is interlobar pulmonary, descending pulmonary arteries. They are looking normal, preserved. What do we say? Yes, hilum overlay sign. This mass is not touching hilum, not from hilar origin. Let's look at the axial contrast enhanced CT. Yes, there is a mass, 5 cm mass, cystic mass, well-defined mass on the right side of prevascular compartment with a small fat density, not obscuring, preserving hilar structure. not touching hilar structure. Yes, this is mature teratoma of young man. Let's look at the facts about the young people's teratoma. Usually, young people's disease, we usually see fat components, and less often we see fluid, calcification, soft tissue, and less often tooth, fat fluid level. They are very rare, but when we see tooth or fat fluid level, we can say confidently, yes, that is teratoma. And actually, mature teratoma is much more common than immature teratoma. How about this young man's frontal PA chest radiograph? Huge mass, big, very big, mediastinal based, very big mass. But please look at the pulmonary vessels, pulmonary artery, and bronchus. They are preserved. Hilum overlay sign. Let's look at the lateral film. This tumor is in frontal location, touching aortic arch. Yes, this is large prevascular compartment tumor. Large means, usually large tumor means aggressive tumor. Let's look at the XR contrast enhanced CT. This very large tumor is heterogeneous enhancement with pleural effusion, invading mediastinal structure and compressing the airway and pulmonary arteries. Very aggressive looking tumor. And let's look at this MIP PET-CT images. Aggressive, large, heterogeneous mass here in prevascular compartment with humerus and multifocal rib, iliac bone metastasis. Very aggressive tumor with distant metastasis. This was confirmed as immature teratoma. This case is a young man's chest AP frontal film. He was so painful, the erect PA film was not possible to take. Let's look at the tumors. Right side, mediastinally broad-based mass, large mass, with obliteration of right heart border, silver sign positive. That means this tumor is attached to or compressing or invading right heart border. And let's look at the bronchus here, bronchus intermedius and descending pulmonary artery. That means hilar structure is not in contact and this tumor is not hilar origin. And we can see the pleural effusion along the major fissure. That's why he was so painful. Let's look at the axial contrast enhanced CT. This is cysts with a solid mural nodule. This is fat density. Attached, compressing right heart border and not attached, not invading hilar pulmonary vessel or bronchus with pleural effusion. Even the pleural effusion is not in clear margin. That's why he was so painful, and this is the sign of a ruptured teratoma. The sign of a ruptured mediastinal teratoma is pleural effusion or hematoma. This was confirmed as a ruptured teratoma. This is the young man's frontal PA radiograph. What do we see? I think now you All of us are very familiar with this kind of image findings. Mediastinal tumor, silhouette positive, hilum ovary sign. So you can say surely with confidence, yeah, this is a prevascular compartment tumor. Yes, correct. This is the lateral film, actually located in retrosternal triangle, prevascular compartment, broad-based on the frontal side. Yes. This is the axial contrast enhanced CT. Yes. Soft tissue mass density with heterogeneous enhancement. Broad-based to the anterior side, frontal side, and mediastinal side, not touching, not invading pulmonary artery. So hilum is okay. Yes, prevascular compartment tumor with high level of HCG. This is germ cell tumor. How about this middle-aged women's chest PA film? Superior mediastinal widening, and right paratracheal stripe obliteration, and look at the tracheal course, somewhat curved appearance to the right side. These two axial CT images, one is before contrast injection, the other is after contrast injection. Diffuse, homogeneous, strong enhancement of this tumor or this structure. Yes, this is the characteristic of thyroid enhancement. And we see why the trachea is deviated to the right side. Yes, this is the extension of thorax goiter into the thorax, intrathorax goiter. Let's look at this young woman's chest PA frontal image. And this is a broad-based mediastinal tumor. But right paratracheal stripe is preserved. That means this mediastinal tumor is not touching at the level of tracheal side. Trachea is okay. And how about this lateral film? I suspect about here, but not so clear, not so evident, just suspicious here. This axial contrast enhanced CT image shows cyst, 2.5 centimeter cyst, homogeneous cyst in prevascular compartment, not touching trachea's outside wall, so that's why the right paratracheal stripe was preserved. This is old women without symptoms, no symptoms. Large mass, well-defined, mediastinally broad-based mediastinal tumor, a large mass. Obliterated right heart border, but preserved hilar structures. Hilum overlay sign with silhouette positive. What is this? Relatively common findings. On the CT axial image, and this is large, homogeneous, low-density fluid, large cyst with a typical aged women, typical side, right side with a pericardial location, typical location. This is the famous area for pericardial cysts. He is a middle-aged man with bilateral mediastinal widening, superior mediastinal widening, obliterating the aortic structure, a retreating right paratracheal stripe with compressing distal trachea, maybe encircling the distal trachea. Even we can see the pleural effusion on both sides. Not good looking, aggressive looking. Yes, on the lateral film, this tumor is anterior and superior prevascular compartment location with both sides pleural effusion. What is this? On this axial contrast enhanced CT, we see many lymph nodes conglomerated in prevascular space on paratrachea. Actually, this is visceral compartment. These lymph nodes are compressing the distal trachea. And let's look at the both axilla. Both axilla is full of lymph nodes, many lymph nodes here, and with pleural effusion on the left side. Let's look at the MIP of PET-CT. How many lymph nodes are involved in this patient? How much tumor burdens are here in his body? Yes, it was confirmed as malignant lymphoma. What about this film? Middle-aged man. This doesn't looking good. This is not looking good. What is this? Heart border is obliterated and inferior pulmonary veins are preserved. Descending pulmonary artery branches, right lower pulmonary arteries are preserved. So not touching lung structures, but compressing right heart border or attached with right heart border. What is this? Without symptom. Let's look at the non-contrast enhanced CT. What is this? Homogeneous fatty density, just as same as the density of subcutaneous fat. Yes, extrapericardial fat, a normal abundant fat density, not in touch with the right inferior pulmonary vein or pulmonary arteries, just prevascular compartment fat tissue. Now the lesson of session 24. The lesions on the prevascular compartment is over. How do you feel? Are you more confident now than before? You did every effort for this session. I congratulate your effort. Thank you so much. Like, subscribe will be a good big support to Dr. Y. Thank you very much and have a good day.